Hi, good morning. Where there is the morning and good evening, where there is the evening. Hi, friends and colleagues. I wanted to present one more topic in front of you people. I hope you will like it. And whenever you like it, please subscribe it and share it and pass some comments. It's me, Dr. Muhammad Kazafi, and you are watching Dr. Muhammad Kazafi Views. Basically, I'm a consultant neurosurgeon since last 18 years and now presenting a case in front of you with the one topic, and the topic is the cerebellar hematoma and cerebellar hemorrhage, or you can say cerebellar hematoma or cerebellar hemorrhage. So I will take one case like analogy, and I will present in front of you, and then we will proceed for this topic. I have a 61-year-old male with a long history of the poorly controlled hypertension, diabetes mellitus, and the history of we can say the heavy smoking history. And he presented to the emergency room with acute decreased level of consciousness. This morning he woke up with the headache, and that has progressively gotten worse. On physical examination, he opened his eyes spontaneously and localizing the on pain stimuli. There is no obvious weakness in his extremities, and we can say the pupils are both 3 millimeters and responsive to light, and the CT scan is obtained and shown there is a dilatation of all ventricles, both lateral ventricle and the third ventricle, but infratentorial slices showing there the hyperdense area in the fourth ventricle, which extending into the cerebellar area, or you can say the cerebellar area, cerebellar parenchyma, the hyperdensity extend into the fourth ventricle. So it is very much suggestive for the cerebellar hemorrhage or cerebellar hematoma. As I mentioned you, it is a real-time patient which we encountered in last 18 years anytime. So when I am presenting the analogy only for the which is correlating with the patient, and we want to see how much my lecture justify with that. So the purpose of my discussion to this topic in front of you, because I want to establish how we can manage the cerebellar hematoma, and how we can highlight the interprofessional team and make up interprofessional team. Simultaneously, I will try to explain some clinical examination finding regarding the cerebellar hematoma, and I wanted to describe few diagnostic and imaging strategies for this patient. Especially, I want to outline the treatment and management option of the cerebellar hemorrhage. Simultaneously, the few detail which I could present in front of you, which is my best of knowledge, I want to present. I want to come again on the history of this patient, what I was presenting in front of you, such as the patient's blood pressure is currently 200 by 110, systolic 200, diastolic 110, and the pupil size in both the 3 millimeter and responsive to light but sluggishly. So this is about his, you can say, the history and some physical examination. First of all, and definitely people would like to know about what is the differential diagnosis could be when we are knowing that the hypertensive bleed account for most cerebellar hemorrhage, and the small number of the The patient can you can say with the present with the small aneurysm of the posterior circulation, that if rupture can give a similar clinical picture as we are watching here. So in that regard, I want to just explain you the frequency of the cerebellar hemorrhage range between 5 and 10% of all intracranial hemorrhage. Intracranial hemorrhage, and if it occur predominantly in the older age group, our patient is 61-year-old, and definitely it consider in the older age group, but and you will find the most of these kind of patients you will find in the sixth decade to eighth decade of the life. And the cerebellar and the cavernomas also bleed, and they bleed and should be considered if the clot is well circumscribed, and usually the symptoms are relatively mild compared to the size of the hematoma. So you can understand we actually explained the differential diagnosis somehow to understand what happening, what we are thinking, or what we have to check for this patient. In a brief introduction regarding the cerebellar hemorrhage or cerebellar hematoma, cerebellar hemorrhage or hematoma is a type of intracranial hemorrhage where the bleeding is located into the posterior fossa or cerebellum, or account for 9 to 10% of all. The posterior fossa is a small space in the skull containing the brainstem and cerebellum. If a mass such as hemorrhage grows in this region, particularly the brainstem and the fourth ventricle, it can block the normal flow of cerebellar or cerebral spinal cord, leading to hydrocephalus, increased intracranial pressure, and symptom onset. Cerebellar hemorrhage can be spontaneous as a result of stroke or secondary to trauma, and occur most frequently in middle age and the older adult, and patient typically have underlying risk factor leading to hemorrhage such as hypertension or small vessel disease. A clinical presentation is dependent upon the size and the location of hematoma, as well as the location and the amount of edema of associated structure in the posterior fossa. The initial imaging modality is typical, a non-contrast computerized tomographic scan, also very appropriate. Management span the spectrum from close observation to acute surgical intervention with optimal timing of the surgery. But here I want to discuss with you some important etiology regarding this patient. The most common non-traumatic etiology of cerebellar hemorrhage, as for all intracranial hemorrhage, is hypertensive vasculopathy causing microaneurysm and resultant rupture. Cerebellar hemorrhage from hypertension most commonly occur in the middle age or older population, often in dentate nucleus with extension to the other areas from the rupture of the microaneurysm along the penetrating small vessel. So, other causes of cerebellar hemorrhage include trauma, coagulopathy because of cirrhosis, disseminated intravascular coagulation (DIC), or thrombocytopenia, or bleeding disorder such as primary and drug-induced, for example, anticoagulation, antiplatelet, thrombocytic medications can cause the bleeding because of these kind of the medication or these kind of conditions which can cause the bleeding disorders. And all primary and drug-induced such as anticoagulation, antiplatelet, thrombolytic medication can cause bleeding. Ischemic stroke with hemorrhagic transformation, cerebral amyloid angiopathy, vascular malformation such as arteriovenous malformation, also could be the cause of the cerebral hemorrhage or hematoma. During arteriovenous fistula, and in the tentorium, it may cause this problem. Simultaneously, cerebral amyloid angiopathy, which is very common in the 6th, 7th, and 8th decade of the life of the patient. So, you know that my patient just entered in the 7th decade and completed the 6th decade, and he is 61-year-old male, and definitely could be the hypertension associated with the cerebellar amyloid angiopathy. Here I want to mention ischemic stroke with hemorrhagic transformation is not very uncommon. It can present. Brain tumors such as primary or metastatic brain tumors can hemorrhage in this case. For example, not for example, actually, and other things such as the septic embolism and central nervous system infection, such as hair encephalitis, moya disease, vasculitis, lupus erythematosus, can cause such kind of bleeds in the cerebellar or posterior fossa area or fourth ventricle. Sympathomimetic drugs such as cocaine and amphetamine also the responsible to do such kind of hemorrhage in the cerebellar or or fourth ventricle area. Aneurysms such as the posterior circulation are the remote hemorrhage possibility, and when it bleeds, it sometimes behave like that. It is the hypertensive intracerebral hematoma. The most common primary central nervous system tumor to undergo hemorrhagic transformation are glioblastoma, but the metastatic central nervous system tumor that have also potential to and they are prone to hemorrhage include the lesions from the lung, breast, kidney, and melanomas. So the cerebellar hemorrhage in younger patients may be due to substance abuse, just such as I told you before, cocaine and amphetamine, trauma, or CNS aneurysm or AVM. I want to discuss a little about the epidemiology of such patients, such as non-traumatic intracranial hemorrhage varies by race and age, but overall it is the cause of 99 to 27% of stroke globally, with an annual incidence of 12 to 31 per 100,000. So, the cerebellar hemorrhage occur in approximately 10% of all intracranial hemorrhage, with low annual incidence of 1 to 2% of all index. So the incidence of the intracerebral hemorrhage increase with age and doubling every 10 years after age of the 35. So my patient is 61, so you can understood if it is considered means 10%, then if we reach to the 6th, 7th decade, so it is considered like the doubling every year. So 60-70% we cannot deny at this moment. Pathophysiology, I want to discuss about this case. The cerebellar location is not unique as far as the cause of intracranial hemorrhage. The prevailing belief is that the patient with the long-standing hypertension have degenerative changes in the penetrating small vessel wall and leading to the subsequent formation of the microaneurysm that rupture and hemorrhage, or the tumors or the blood disorder, amyloid, arteriovenous malformation, trauma, and simultaneously drug abuse may also lead to cerebellar hemorrhage. And remote cerebellar hemorrhage after craniotomies is thought to be a result of loss of cerebral spinal fluid, so causing a sag or sagging effect in the cerebellum with resultant venous blood bleeding, often tracking along the superior cerebellum, with most cases having a benign course. But as I mentioned, in a few things I want to mention about my patient here. You know that the posterior fossa, arteriovenous malformation, and the perinoidal aneurysm should always be considered and needed to be ruled out from the differential diagnosis, and the lesion should be treated aggressively because it has a significant higher risk for the rupture, almost 9 times higher than the supratentorial AVM. It means the infratentorial AVM are more prone to bleed as compared to supratentorial. The history of the diabetes in this case is also considered a general higher risk factor for developing a cerebellar hemorrhage. Intratumoral bleeding should also be considered in differential diagnosis, and cerebellum is a common location for the brain metastasis, and some tumor may prone to bleed. So usually the CT scan will show a heterogeneous density appearance with significant surrounding edema. Now, what is the most likely diagnosis? Definitely, we know that in our case, the cerebellar hemorrhage seen on our CT scan, this 61-year-old male is most likely due to the hypertension. And when we discuss what kind of the recommendation for surgical intervention on cerebellar hemorrhage, so the recommendation for surgical intervention include patient with the Glasgow Coma score less than or equal to 13, or with hematoma size more than 4 centimeter or equal to 4 centimeter, then the surgical intervention will be on, or we can consider for the surgical intervention. Likewise, when a ventricular catheter placement is recommended for patient with the hydrocephalus and no coagulopathy, and we have to correct for the any coagulopathy if there is there. The most cases with hydrocephalus also we can say here that we should correction for the hydrocoagulopathy and introduction, or we can say the use or the insertion of the ventricular catheter placement recommended for the patient with the hydrocephalus, and the most cases with hydrocephalus also require evacuation of the hematoma. So the ventriculostomy drain help a lot to remove that clot. The presence of a tight posterior fossa concept described by the Westberg and et al. They warrant surgical intervention, and Westberg defined that there is the obliteration of the basal cistern of the posterior or cranial fossa. It is a major indication for the surgery, and enlargement of the third ventricle, lateral ventricle, and the temporal horns. It is also suggestive we have to intervene and to decrease the problem of the posterior fossa. Engorgement, or we can say tightening. Enlargement of the third ventricle and lateral ventricle and temporal horn cannot be avoided at all. Effacement of the fourth ventricle also very important factor. The TPF does not depend on the size of the hematoma. The hematoma of similar size may exert widely different amount of compression influenced by the several factors such as patient's age, the amount of cerebellar atrophy, and the anatomy of the brain, generally how it behaves. So here we have to careful for the posterior fossa when we are talking about the tight posterior fossa, or we can consider TPF based on the concept of the critical size of the hematoma. Evacuation can be reduced at 5 to 10 millimeter or from the 3 centimeter. So how we can describe or how we can present how I will present my surgical plan. So my surgical plan, initially the ventricular catheter I placed, I inserted, and I have two options. I can choose the Cocker's point or the Frazier's burr hole site, and 2 to 3 cc of cerebral spinal fluid is drained slowly to control the intracranial pressure, and then the drainage is stopped to avoid upward herniation of the brain. A suboccipital craniotomy is then performed I perform the suboccipital craniotomy and with the goal of removing the intracranial hemorrhage and decompressing the brainstem and relieving the hydrocephalus, the external drain I put, and it has been opened after the dural opening, because when I open the dura, now I actually counter the tight posterior fossa effect, and upward herniation can be avoided, even though if I replace some more CSF. A transverse incision along the folia and closest to the most superficial part of the clot I performed, and after removing the intracranial or intracerebellar hematoma, the meticulous hemostat I applied and hemostasis achieved, which is very much necessary to obtain, and then blood clot, and I sent for the pathology because I was suspecting it was very hard, and I wanted to see if there is any element is involved, so I should know by that. Usually the cerebellum itself will usually swell after the surgery, and it is better to close the dura via duroplasty, and I always prefer the dural plasty or dural augmentation, posterior fossa dural augmentation with the help of a pericranium, or if we have some we can say the allograft is available, we are using that. I am very much using that, because in posterior fossa I am very particular to close the dura. In the meanwhile, you know that the ventricular catheter is, and in general, is kept means temporary, and you no need for longer period of time, but sometime it may need to convert into the VP shunt, but it is not means very much common, but can means use or the indication cannot be denied at all, and sometime I put the converted from this temporary to permanent ventriculoperitoneal shunt. One thing come in mind, after if somebody open the dura and observe with very swelling and tight cerebellum, so what should be our step to stop and managing intraoperative brain swelling? Actually, the few checklists I made for this such kind of the problems, and I want to present in front of you humbly that the following is the checklist of steps to ensure the proper management of the intraoperative posterior fossa swelling to elevate the patient head to above 30 degrees, check neck position for obstruction of the venous return and readjust as necessary. Hyperventilation to the partial pressure of the carbon dioxide of 30 to 35 millimeter of mercury, and because we need the partial pressure of the carbon dioxide should be between 30 to 35. Usually you can take you can keep between 35 to 40, but I want to make a little lower side so I can achieve some less swelling, or can achieve some benefit of that. It should be very much controlled. Central lines and arterial lines should be placed, because without this, these things you cannot achieve. Hyperventilation for the For the partial pressure of carbon dioxide, it's proper. It's totally a proper topic. I hope we can discuss somehow. Infuse a dose of mannitol and or laxis sorry Lasix, and we can give here, and we have to give ensure the adequate sedation and the pharmacological muscle and paralysis. Usually the interventionist usually doing in our setup, and we are always requesting them for these things. So as you know, the decompression, the hematoma rapidly and appropriately draining some CSF by ventriculostomy, opening of the cisterna magna and drain some CSF, some more CSF, and one may need to resect part of the cerebellar hemisphere. It is, I don't like usually, but sometime it has to do. If you have to do, then you have to do. So then ensure that the foramen magnum is open, keep open, and if the swelling is still uncontrollable, then definitely considering the following cause. There are maybe intraparenchymal hematoma, it is in other location. Repeat CT scan such as contralateral or supratentorial, subdural or epidural hematoma, we have to check it. Also cytotoxic edema from the trauma, we have to check it. Also venous infarction or some intractable cases, some of the following steps may be considered, such as duroplasty, and quick closure is very important in that regard. So as I mentioned, and as I presented this case in front of you, so leaving the bone flap out or craniotomy or craniectomy, considering it also an option. Obtaining an emergent CT scan of the head and considering going back to the operating room for the further exploration, and there is no shame for that, because if patient behaving like that, then you have to treat it aggressively, because otherwise you may lose the patient and it is not good for anybody. Sorry. In the past, exploratory supratentorial, as I was mentioning you, that in the past exploratory supratentorial burr hole were suggested. However, with the advent of the fast spiral CT scanners and or mobile intraoperative CT scanner now available, so these unwanted unwanted intervention has been avoided much. So that's why we have the habit. But for the security of the patient, if we find the thing another, then we have to intervene accordingly. I want to mention here a few things that we need to take care for post-op cares, which is very important to discuss here. The post-operatively, the patient should be monitored in the ICU intensive care unit for at least 24 hours in anticipation of the peak of the swelling. Blood pressure should be closely monitored with the arterial lines and controlled closely with intravenous or we can say the antihypertensive we should use here if we need it, such as the nitroprusside or nicardipine we can use. Patient with the critical neurological condition remain under mechanical ventilation, and in certain cases consideration of the corticosteroid may be the reasonable option. I prefer sometime to use dexamethasone 10 milligram IV once and then 6 milligram IV every 6 hourly, and it is giving some kind of benefit to my patient. And other agent we can also administer as per need to reduce the intracranial pressure. Post-operative CT scan should be obtained within 24 hours, and after the patient's neurological condition improve, he may be transferred to the neurosurgical ward and subsequently discharged from the hospital once the blood pressure remain under control with oral or we can say antihypertensive. Here I want to a light suggestion that this post-operative CT scan we did, and we found there is a complete clear of the posterior fossa hypertensity. Only a small amount of blood products element we can find. It was scattered in that area because hemostats I applied, and because I left the ventriculostomy drain, so the ventriculostomy drain I could find in the post-operative CT scan. But as you know, and these all things are very very important, because the treatment is very very important, and you know the prognosis, the mortality associated with the cerebral hemorrhage can range from 25 to 60%. And following surgery are strongly correlated with the patient's clinical status before surgery, but we favorable in our half of cases. So the recommendations are therefore that there the absence of multifocal comorbidity, surgical intervention should be pursued even in patient with the poor post-operative neurological, poor pre-operative neurological status. So we have to intervene, and we don't have to avoid and wait unnecessarily. Regarding the treatment, I already mentioned, but I want to conclude in that manner the treatment of the cerebral hemorrhage, because before I told you what I did. Now I want to give you some in lecture few pointers for the treatment, or you generally we have to consider as in detail. Treatment of cerebellar hemorrhage is depend on the size of the hemorrhage in addition to the clinical presentation. Airway protection with endotracheal intubation may be necessary for patients who present with severely altered and depressed level of consciousness or altered mental status. Neurosurgical consultation should be obtained urgently after diagnosis to assist with optimal management and treatment. A small hemorrhage without significant mass effect can often be managed conservatively with admission to a critical care unit capable of frequent neurological assessment. A large hemorrhage, typically greater than 3 to 4 centimeter, may require surgical intervention and evacuation, particularly if associated with edema, intraventricular extension, brainstem displacement, or hydrocephalus. In that scenario, you don't have to wait, you go for the surgery immediately. If patients are intubated, normocarbia should be maintained. There is no need for prophylactic hyperventilation except in extreme cases of impending brainstem herniation, and it should only for a short period, because the corticosteroid usually not showing a significant benefit, but corticosteroid sometime post-operatively giving some benefit, and I am sometime I have to give post-operatively. Patients with the cerebral hemorrhage often have acute blood pressure elevation as in any other case of the intracranial hemorrhage. It is often a fine balance to minimize hemorrhage growth and increase intracranial pressure while maintaining cerebral perfusion is also should be prime. A recent consensus recommendation believe it that safe to lower the blood pressure to less than 140 mmHg systolic And in American Heart Association guideline, which was introduced in 2010, and they are telling the management of blood pressure in intracerebral hemorrhage suggests value less than 160 by 90 mmHg or mean arterial pressure less than 110 mmHg. It should be okay, and the body temperature should be maintained within normal range. And if the patient does develop an elevated body temperature, pharmacotherapy and cooling measures should be instituted to maintain a core body temperature for lower than 37.5 degrees centigrade, as the fever has been shown to worsen outcome in the injured brain. So the current evidence does not support hypothermia for cerebellar hemorrhage, and maintaining normal glucose level is necessary as a hyperglycemia as correlation with poorer outcome in patient with the cerebellar hemorrhage. Hypoglycemia should be avoided, but current practice suggests that the reasonable glucose level of 100 to 180 milligram per deciliter is very much advisable and appropriate. In the intensive care setting, insulin therapy over oral agent is preferred because in intensive unit you can check frequently. Intensive compared to conventional glucose control did not demonstrate any significant difference in clinical outcome. Normovolemia should be maintained with isotonic fluid with appropriate correction of serum electrolyte such as sodium, potassium and magnesium. Mild hypertonic fluid such as 1.5% hypertonic saline may be used to correct hyponatremia. Cardiac arrhythmias may occur with injured brain, and it is important to keep the potassium level above 4.1 millimole per liter and magnesium above than 2 milligram per deciliter, so do not aggravate arrhythmia. Anticoagulation and antiplatelet medications should be immediately discontinued in case of cerebellar hemorrhage. The reversal of the coagulopathy should take place with appropriate reversal agent, such as patient on the warfarin should receive vitamin K and the factor replacement in the form of the fresh frozen plasma or the prothrombin complex concentrate. It all are advisable as per need, both of which are effective, and the factor replacement with PCC or 4-factor PCC should be attempted in patient with novel oral anticoagulants, but supporting evidence is limited, and platelet replacement therapy in patient with antiplatelet medication or those with thrombocytopenia and platelet count less than 50,000 is often performed with severe bleeding and before surgical intervention, but the benefit is still unknown. So, in that regard, as I mentioned the few pointer regarding the treatment, now I want to address very important part of my lecture, which is needs few minutes from your side. That is the complications. And so the significant cerebral hemorrhage may have a perihemorrhagic edema and mass effect, which unfortunately can cause multiple complications, include brainstem compression, cerebellar herniation, compression of fourth ventricle with resultant obstructive hydrocephalus on extension of hemorrhage into the ventricular system, and the current hemorrhage typically within the first 24 hours. There are two options for managing the mass effect from the cerebellar hemorrhage, which is the hyperosmolar agent or decompressive surgery. Osmolar therapy is used to reduce the space-occupying effect of the hemorrhage and edema by increasing serum osmolality and facilitating the osmotic movement of water into the vasculature and resultant reactive vasoconstriction. The goal is an overall reduction in intracranial pressure and tissue shrinkage, there is no superiority of hypertonic saline over mannitol or vice versa for the treatment of intracranial hemorrhage. Hypertonic salines concentrate typically utilized for the treatment are 3%, and the boluses and the continuous infusion have a goal of sodium level of 145 to 155 millimole, and the osmolality of 310 to 320 should be considered. Complication may occur with infusions such as hypotension, pulmonary edema, heart failure, respiratory failure, coagulopathy, hypokalemia, what we say the intravascular hemolysis, encephalopathy are there. But mannitol is a sugar alcohol, as you know, that act as a diuretic and usually administered as a 1 to 2 gram per kilogram bolus and 20% concentrate. It is ideal with additional dose of 5.5 gram per kilogram every 4 to 6 hours, and it is imperative to maintain euvolemia during its administration, and caution is advised in patients with the renal failure, as the mannitol may lead to the fluid overload and necessitate dialysis shortly after administration, and serum osmolality should remain at less than 320 milliosmol per kilogram, which is near to the normal level, and to avoid to prevent the renal toxicity, further renal toxicity. Decompressive surgery of choice is a suboccipital craniotomy with hematoma evacuation, as I did, and the surgical option is necessary when the patient neurological status continue to decline due to the brainstem compression or obstructive hydrocephalus. It appears secondary to the mass effect of the hemorrhage and the pre-hemorrhagic edema. An external ventricular drain may be used to treat the obstructive hydrocephalus as an alternative to the surgery or in addition to the surgery. Criteria used to select the patient for surgery and the external ventricular drain placement have their basis on both clinical presentation and radiographic features such as the size of the hematoma, ventricular extension, hydrocephalus, brainstem compression, and hydrocephalus may be treated with close observation in an initiative care setting without surgery. A stereotactic burr-hole aspiration is an option for the patient with a smaller hemorrhage, but is still under debatable circumstances. So, how you create the difference? Actually, most cerebellar hemorrhages are hypertensive in origin, and the patient suffering from the hypertension should receive education so that they are aware of all the potential risks and the complication associated with poor control of their disease process. These patients should be encouraged to seek medical attention urgently if they develop worrisome symptoms. So in that regard, we have to take care and we have to develop a proper team who can work together, which constitute over the neurosurgeon, neurologist, primary care provider, intensivist, and acute practice provider. So these all are very, very important part of this team. Thank you very much. I tried to explain in detail the important pointers regarding this problem, which is the cerebellar hematoma or hemorrhage, and I took the case for the analogy of the hypertensive bleed. So I hope you will like it. If you like it, please subscribe and share my videos with others.